Okay, hi everyone. So on Friday we're going to have our exam practice session 1. So please take a look at the syllabus. Everyone is in a group, as you know, because you should be sitting in your groups. But your group number will be by your group. So we've kind of broken everyone up into small groups, and so that you can have a specific facilitator. So we're going to give you guys, we're going to run it as much like a practical as we can. So we'll give you the specified 20 minutes to work up the case, and then we'll give you guys some time to discuss it amongst yourselves. And then we want you to kind of practice within your groups, and then also in the larger small group, stating what you think the drug therapy problems are, your rationale, your plan, and monitoring, just like you would do on the practical. So we'll discuss those things, and then at the end, you'll see Dr. Lavender again kind of presenting the patient case, so kind of that answer, if you will. So a presentation of the case, like what you would do in the practical, all right? So be sure to bring your computers, and you'll be able to access information like you would in the practical. During our practice session, the environment won't be controlled like it will be in the practical, but just know that you'll have access to the things on the UGA, on our College of Pharmacy website, and then also you probably would want to look on the internet for guidelines. All right, questions? Okay, see you Friday.
Alright guys, well I'm happy to spend some time with you this afternoon. I don't really get to teach as much in the third year of the curriculum. I hang out with the OTC folks. You guys remember those days? You don't miss those days, right? No. As well as obviously second year pharmacotherapy. So in this semester, you will see me in this course in the practicals. I typically facilitate some of the practical sessions. And then I do some sessions in applied pharmacy practice later on this semester, some of the mock case presentations and things like that. So I'm back, I'm here, but I'm glad to see you. So I think we can work this class session a couple of different ways. Certainly I hope we can have some good discussion today. But understanding that it might be a few days since you worked up this case in detail, would you appreciate a couple minutes just to meet with your group and kind of go through some of the ideas you have for this patient?
Sure.
Okay, I'm seeing some nods in Athens. So what I'm going to do, 12:34, let's just take until about 12:40. Powwow with your group. If you didn't already work up the case with them, now would be a good time to discuss some of the ideas that you have for this particular patient, and then we'll bring it to discussion in about 5 minutes.
What's up?
Okay, I made the guidelines like are you supposed to like if you have the leg because it's so like treat it with the antibiotics because it says like it's supposed to be like infusion or drainage for the leg.
You could treat it with that.
Huh?
You could treat it with antibiotic.
I think it's like kind of misleading because in the note they put mild SSTI, but like to me, if you have a wound that's like oozing out shit, I'm not gonna just do like
Drain it.
Like that's disgusting.
There's talking about giving antibiotics.
No, she was just asking if she would give them an antibiotic or not. Because like technically for a mild one, you just IV it, but I was like,
Per their guidelines. Mild outpatient use also.
So what were y'all's main problems? Diabetic foot ulcer, diabetes uncontrolled, statin use to be high intensity, and
I think I did mine in the same exact order.
I did. We need to counsel her on her
the
insulin.
hypertension.
And then
Yeah, I did ID interventions, diabetes, hypertension, hyperlipidemia, and then I was like,
She couldn't do a
assess her
GLP-1
chronic.
because she has a trouble with cost, right?
Yeah, but
That's why I didn't think about adding it, even though the guidelines say it. Like, it's really expensive.
But if this was like a Mercy patient, they could probably get a medication assistance and get it paid for. Which is why I think she's the one who's like doing this case, because she lives at Mercy. So this is probably one of her like old patients.
For the diabetes, I just said increase insulin like 3 units before.
I essentially give her a dose like in clinic,
Yeah.
and then explain to her again how to use it, and then have her come back in like a week.
Oh, no. And statin, I did a Torvastatin 40.
Yeah, I just
And
changed
lisinopril
it.
40.
Yeah, no. Yep.
And what is the good dose of vitamin E? Like, and what's in her multivitamin? Because I don't know how much vitamin E she's getting. I'm sure she'll
Yeah.
say something about it.
Yeah.
We don't
We
know.
don't know what multivitamin it is.
She was in high intensity group, right?
Yeah, she needs a high intensity, but she wasn't getting one.
Paul was high intensity.
Was it? She's diabetes and she had a stroke.
Exactly. So I was
So
like,
she's like super
I don't know why.
Her ASCD is over the limit too.
Oh, what did you put for like what's wrong with her like current regimen?
Or what?
Like current regimen. Like it was like hydrochlorothiazide dose is too high, or like lisinopril like side effect, and then
Oh, it wasn't either of those.
yeah, it was like Humulin, right? Yeah.
So what?
It was like inappropriate Humulin like dosing. Yeah, the timing of it. Yeah, because you're supposed to do meals, right?
I thought she was doing it before me.
She was AM and
In the
PM.
morning and the evening.
But it said
It was just
bedtime.
twice.
It did say before breakfast on
Yeah.
the first
That's
one,
what I
but
thought
the
it
other
was.
one said before bedtime.
Did you guys increase her dose or add a lunch dose?
It increased the
Increase
dose.
it by 10.
That's what I
You
thought.
get insulin over the counter at Walmart.
I think you
There's some pharmacies where you can just like buy it.
I literally.
Yeah,
And it's not like
I think you
$25.
can at Kroger too, actually. I think that's what
Walmart has a generic of like regular, or it's like Novoland.
the Walmart, yeah, it doesn't even do
I want to buy one just to have it.
Just to I mean, you keep it in the fridge, you could like use it eventually.
I mean, if I ever wanted to like, if I ever wanted to get lightheaded, I could just get high on it.
help, I'm sick, I can't take this test today.
Sounds like a perfect way to get at a seminar, but you already did yours. You just like stand up and be like, and then just like pass out.
Wouldn't that be fun?
Die because your blood sugar dropped too low.
It'd like take you. Like,
Oh,
they'd
it's
probably
supposed to
rush
be
you
units,
past
not
the
mils.
days.
Oh
20 units. Oh, I thought that meant
no. 20 mils. Just kept injecting it.
Oh, jeez.
Through vial after vial.
Oh my god. How quick would you die if you injected 2,000 units of insulin? Like, that's how many it would be.
Something would shut down immediately.
I don't even know.
I could
What
be
would go
diabetic,
first?
so I couldn't like give myself injections.
Pretty fine with that. I couldn't do drugs. I couldn't like put it in my vein, but I could stick it under my skin.
Worst. I hate watching veins.
I don't know, maybe after I saw the reward of the first dose, I could keep doing it.
No.
That's probably why like people are like getting over it.
See, whatever's happening to Brielle's computer scares me.
You still haven't gotten
No,
your
I
other
did.
one?
Well, okay, so here's the issue. So I got the one without the touch bar. The one without the touch bar was the 2017 model. If I want to get the updated one, I have to get the one with the touch bar and spend like $500 extra.
Well, now it's like you're not spending $2,500, you're just spending $500 because you've already spent that
but I
money.
was like, I'm just gonna keep the one I have, and I'm just gonna convert or like start using it.
Is there? You got a Pro?
Yeah.
It's still like this color and everything, right?
It's the same, it's just like, I do like that one has a quad processor, like the quad core, and then the one that I have only has a quad core.
I feel like this definitely matters if you're like into
Like,
gaming,
If you're like coding.
and doing Adobe Photoshop.
Like all those stuff, but I'm just, hopefully by the time it dies, I can afford another one.
I mean, you should be.
Right.
All right, guys, so we feel like we've had enough time in our groups.
Is it about 35 for over 40 for diabetes and statin?
Okay, wonderful.
40?
So again, I know this is still a relatively new course in our curriculum, but I think this is probably one of my favorite courses to be involved in because this is
Did you guys
really the
put
class where
both
we're trying to get
Spectrum
you
and
ready to
Augmented
go
or
on
just
vacation, right?
okay?
And I know that you've heard this from other faculty facilitators, so I shouldn't be saying anything that's brand new. But what I'm finding now that I have students on rotation that have been through the new curriculum is my current T4s are just much better prepared to come into clinic, work up a patient, present that patient to me, and really, start to formulate an assessment plan. So I think that's cool. Rest assured, you guys are getting good experience in the classroom doing it. But obviously, it also takes practice. So hopefully, what you've seen in this case is there are some really common disease states that we're hitting on here that you should feel confident seeing again and again, right? A lot of these things that you're going to interact with patients who are being managed in the outpatient setting. So hopefully this case was appropriately challenging for you, but also, made you think a little bit about how to prioritize problems. That's really my goal here, okay? This case is based on a real patient that I interacted with at Mercy. Of course, HIPAA stuff has been changed, and there's some different features about the case that I edited just to make it a little bit easier for the classroom. But this is a real patient encounter and presents, again, a lot of the things that I feel like I see actually in practice. So hopefully you guys enjoyed working it up and you've learned some things already. These are going to be our objectives for the day, which are just a summary of the objectives in your syllabus. So we're going to try to hit on each of these things. Mostly what I'd like is for you to talk to me. So I'm going to try to ask you some questions here and there and prompt some discussion. But I really hope that you guys will feel comfortable just speaking up. And that's, of course, for all of our campuses. I can see you guys on the other campuses. You're small, but I can see you. So please don't be afraid to hop in, raise your hand, jump up and down, whatever you need to do to make sure that everybody can join the convo. Okay?
Okay.
Any questions before we get started? No? We ready to rock? All right. So the first things that I think about when I'm going through the electronic record is what has the patient told me, right? What is pertinent subjective information in this case? And when I go through and I work it up, I do kind of still do a SOAP format just because that's how I was trained. And obviously in Ampere, I document every patient encounter that I have. Sometimes brief, sometimes lengthy, but it's all in SOAP format. So that's why really where I'd like to start today is what are the key pieces of subjective information that you pulled from this case while you were working it up. So shout them out. Absolutely. So I heard she ran out of insulin 4 days ago. So I think from here, so excellent, that's a really big key piece that you guys should have keyed in on pretty early. From here, I think we can start to divide our conversation up into what's going on with the patient today when she presents to clinic versus her historical information, right? So let's stick with today. So what else is key that she's reporting to us today, other than that she ran out of insulin?
She has a blister on her foot that turned into an open wound.
Okay, so we've got some sort of foot blister, right? Callus, something that happened that has turned into a wound. Okay, what else is important about that? What other things does she report?
It isn't healing.
Give me a hand raise. Okay, what did you say?
It isn't healing well.
It isn't healing well. Okay, so why do we think this blister on her foot is not healing?
Unforced circulation because of her diabetes.
Okay, so absolutely that's part of it. And Adacia, I think you were going to say something else. Same thing. So we definitely think circulation, right, and just perfusion to the area. There's something else that's important that keys into what's going on with her diabetes today. Yeah, so she has uncontrolled diabetes, right? So what happens when our blood glucose stays high? It's going to impact a lot of different things in our body, right, including wound healing, okay? So absolutely. So we know she's come in out of insulin, and she's got some sort of a sore callus on her foot that's turned into a wound. What else?
She takes a flea market multivitamin.
Okay, so we've got the she She may have gotten it at the flea market, absolutely. Or local grocery store, wherever, or family member, right? So this is going to key into an important part of our med rec, right? So in the outpatient world, my advice for you always is going to be ask a follow-up question, right? So if a patient reports something to you and you're thinking, something's not quite right about that, always okay to keep digging, right? So what kind of vitamin is she taking or supplement, do we know? I hear somebody saying seed. Yes. So again, based on a real patient encounter, right? So I want to stick to acute now, but we'll move to just her history in a moment. The use of that seed and whatever she's purchased, right, from the market is impacting her ability to take her medications correctly, right? So absolutely, that's an important part of this objective. Okay, so acutely in clinic, so we know she's got a foot wound, right? She's out of insulin. So if the patient comes into an AM-care setting and they have run out of their insulin, run out of their diabetes medicines, what kind of questions should you be asking them?
How have you been taking it?
Absolutely. So we want to verify previously prescribed, right, doses and products to make sure we know how she was taking it before she ran out. I'm thinking along the lines of symptoms as well. So what do we want to know about her today?
She denied any excessive thirst or polyuria and other things. For blurred vision.
Yeah, perfect. So we want to make sure that if she's having symptoms of hyperglycemia, that we're making the decision then on whether or not she needs further treatment, right? So if she was having blurred vision, increased thirst, increased urination, then we might start to be concerned with something like dehydration, right? And do I need to triage this patient to another setting? So absolutely, that's important. So patient denies symptoms of hyperglycemia. Any guesses why that is? What's her blood sugar today, do we know?
3 something.
Upper 300s? Right? So what are you taught in school? When do you get symptomatic from hypoglycemia? It's greater than 250, greater than 300. Why is this lady asymptomatic? This is not the right answer. I'm just soliciting.
Maybe she doesn't like to complain.
Say it again.
Maybe she just doesn't want to complain.
Okay, so maybe she's just not disclosed this information to us, right? Maybe the person that met with her didn't ask and she's not giving us anything extra, right? That's highly possible, absolutely. Sometimes what I see in practice too is that the symptoms of hyperglycemia can be vague. And so patients can have these symptoms and not really connect it with, oh, my sugar's high, so this is why I'm feeling that particular way. The other thing that I see is our bodies are compensating for quite a bit, right? So if my A1C is 10, she's not quite there, but if my A1C is 10 and I've been hanging in that realm for a while, I might not be recognizing that I'm feeling poorly, even though by the numbers, right, I might be hyperglycemic, okay? What else about her today is important? Subjective. Anything else on your lists? Other campuses, I want to bring you guys into the conversation too. Anything else on your list for acute subjective? That's okay with me. I think we've hit on the main things that I've touched on. So I created a brief slide set. This is something that I changed from last year because I felt like a little bit more structure in the classroom was helpful for you guys. So I do have some slides that I'm going to run through today, and I'll post those on ELC afterwards. But this is going to help me keep my thoughts together too. Okay, acutely, today in clinic. So we want to make sure that we ask a few more follow-up questions, right, about her description of the toe wound. So we know that it's not healing. We want to ask if she's tried anything already and just her level of pain. But the way the case is built, as you guys have seen, is patients come in today and seen another provider, right? And the provider's curbsiding us and says, hey, look, this lady's out of insulin and, we'd like you to assist. So they've already made a decision, in essence, about her toe wound, but it's important that we know these these facts. She's disclosed non-adherence. She's been out of insulin for over 4 days, and as you guys have noted, she is denying signs and symptoms of hyperglycemia. Okay, so we need to consider first about how we're going to manage this patient today, right? But I think before we go down that one, let's think about other subjective information that we know about this patient that is important. So what else is on your subjective list? Okay, so we know a little bit about her social situation, right? So she's a widow. Do we know who she lives with? I think she lives by herself. She has adult children, right? Is she working? Okay. What kind of job does she have? Okay, why is that important? She's on her feet all day, right? So as we get into a more in-depth discussion about insulin therapy and adjustments and dosing, again, in the outpatient world, you know, these are things that I spend a lot of time with people on because I need to know a little bit about their day-to-day routine and their day-to-day life so I can make appropriate recommendations for how to best use medications for them. So yeah, I think we've got some pertinent social history here, as well as what type of job she does. What else could be considered subjective? I want to hear from somebody in Albany. I see you guys in the middle. So what else is on your list for subjective information?
Her self-monitoring blood glucose levels.
Perfect. So I heard self-monitoring of blood glucose. Okay. So this is oftentimes subjective, right? Because this is something the patient is reporting to us. Now, if the patient brings their meter in and we've got a little bit more to go off of, we might feel a little bit more confident about those values. But a lot of times patients might come in and say, well, you know, my sugar usually runs in the 200s. So again, we need follow-up questions there. But we do have some recent self-monitoring for her. So what kind of self-monitoring do we have? I'm going to stay with Albany here. What kind of numbers are we seeing at what time of the day?
Before breakfast and before dinner.
Sorry, I need you to speak up. I heard breakfast.
Before breakfast and before dinner.
Okay. So we've got some readings before breakfast and before dinner. Does that make sense based on her insulin regimen? I think so. I think so. What kind of numbers are we seeing before breakfast?
They're good before breakfast.
They're good before breakfast, right? What kind of goal are we shooting for there?
$80 to $130.
Yeah, absolutely. So she's got goal readings at or before breakfast. Why do we think that is?
Because she's taking her nighttime insulin, but not the morning insulin.
Yeah, absolutely, absolutely. So she's taking, this is an important part of her subjective as well, and it ties into her self-monitoring, right? So it sounds like she's taking her nighttime insulin, but what's happening with that morning or daytime dose? I hear you guys saying it.
She's not taking it because she doesn't want to take it with the seed.
Yeah, absolutely. So this all connects, right? It's kind of an overarching theme of non-adherence, right? Or maybe suboptimal adherence, right? Because patient is perceiving that this supplement that she's taking in the morning time is helpful for her diabetes. So she's skipping her morning insulin, right? Which has resulted in some self-monitoring later in the day that's not great. Okay, excellent. So that's a really important part of her subjective information. What else? So we've talked about supplement disclosure. What else should go on subjective? Absolutely, her diet. Yeah. This is, remember guys, what the patient tells you. I know you guys know this. So what's significant about her diet? So Diane, what do you think? She got some calorie dense meals, right? So again, I'm thinking about what is this patient's day-to-day life like and how can I optimize her medications based on that, right? If she is a waitress, she's on her feet a lot, she probably doesn't have a ton of time to eat, right? And maybe she's eating foods that are at the restaurant or she brought from home, we don't know. But yes, from what I can see in her meal recall, she does have some calorie dense choices, especially in the middle of the day, right? So I would include this on our subjective as well. Anything else? Anything we missed about subjective? What about the med list? Could that be considered subjective? Yeah, absolutely. So we want to make sure we can verify that to the best of our ability with refill history and things like that. But if a patient comes in and says, oh, I'm taking something else for my blood pressure, whatever the case is, that could certainly be subjective as well. So these are some of the things that I thought of that I think we've hit on. So again, what's historically important for this lady? Her self-monitoring, her meal recall, physical activity, the meds that she reports, and the supplements that she discloses. Okay, let's talk objective, and then we'll get into our prioritization of problems. So what kind of objective information do we have from today's clinic visit? I'm going to throw it down to folks in Savannah. What do you guys think? So objective information from today's clinic visit.
Her blood glucose.
Her note about the diabetic connection says that it was ½ inch and it was pregnant.
Okay, absolutely. So looking at the note from her visit from the provider and getting a little bit more detail about that wound, right? So we could list that, absolutely. So purulent, mild swelling, right? We know that it's not healing. Again, on her feet, right? She's probably wearing maybe not great shoes, we don't know, but something's rubbing on the part, preventing it from healing, and her sugar's been high. So, okay, good. What's another key piece of objective information from today? We already briefly mentioned this, but I do think it's important.
Blood glucose 376.
Yes, absolutely. So blood glucose is 376. Okay, how about some other historical objective info? So those are the two key pieces that I pulled from today's visit, but we have a lot of other objective information from this lady just in the past couple of months. So what else is significant?
I have a quick question.
Yeah, please. Where are you at? Yes, let me see. Yeah.
Does her old subjective information now become objective since it's in the past and you found it in the patient's chart?
I would say it depends on what it is. You know, if it is still a statement that the patient has made, like, I feel this way, I would still consider that subjective. If you've got a verified med list, verified past medical history, all of that, I would consider that objective. Yes. Yeah, absolutely, absolutely. So past medical history comes into play. What kind of significant past medical history does this lady have? So we know she has type 2 diabetes. What else does she have?
She had a stroke about 5 years ago.
Okay, so she has a past medical history of stroke, absolutely, and that event happened about 5 years ago. Any deficits from the stroke that we need to be aware of?
No. Left-sided weakness.
Does she have any balance issues?
She's a little weak on the left leg.
Okay, so she's got some weakness, so that would be important. Again, think physical activity, right? If we're recommending something for this lady, it's important to know she's had a stroke prior, but seems to be doing pretty well. What else is significant for her?
She has hypertension and
She's got hypertension and, sorry, go ahead.
obesity.
And she's obese, okay. Anything else? How about prior infections? So we're concerned about an infection today, right? And we know why we want to treat that, I think. But does she have a history of any kind of infection? Has she ever had a diabetic foot ulcer before? I don't think so, not that I can find. Anything else in her chart that shows up?
Yeah.
It said something about bacterial cystitis on the like pre-thing, but we didn't know if that was like messed up or correct.
Okay, so it might be, I think that's intended to be past history, so like previous UTI or something like that. Yes, but that's a good call. No other infection today that I'm aware of other than her foot. Okay. Okay. Let's dig a little bit deeper into the meds for a minute while we're talking about objective info. So there is an issue with something on her medication list. And I hope you identified it. I think dosing. Anybody see something funky on her med list?
The insulin.
The dosing of the 70-30?
Yes. Sorry, who said that? Give me. Thank you. Absolutely. So what's off about the dosing of her 70-30?
It should be 2/3 in the morning and 1/3 at night, but she's not taking it, so it doesn't matter.
So does it have? Okay. Does it
The
have
last
to?
part was a joke, by the way.
I got you. Does it have to be 2/3, 1/3?
No, but that's optimal.
100% days.
If you're starting somebody, are you thinking about initial dosing?
Would we consider initial because she hasn't been taking it, so it's pretty much like she hasn't been on it?
Yeah. So I'm unpacking it a little further. So what is Humulin 70-30? What kind of insulin is in there? NPH and regular, right? So how long does it take that product to start working? What's the onset of action? About 30 minutes, 30 to 45? Yep, because you're going to go with the short-acting component, right? So what time should she administer the dose? I heard somebody say before she eats. Okay, so ideally before her first meal of the day and before her last meal of the day, right? I usually try for at least 6 hours, maybe even 8 hours between doses there. So how is she currently using it, or how is it on her med list? This is what I'm getting at. So not that your comment is incorrect about dosing. This lady's been on this product for a while and she certainly has some adherence issues, so I think we can talk dose adjustments and what might be indicated. But I'm thinking more of the timing of her dose. I hope it's on there. I updated it in the medical.
It's 12 units before breakfast.
Thank you.
35
Yes. Okay.
units
And that's
before
what I
bed.
say. Yes. Thank you. So should premixed insulin be dosed at bedtime? No. So I put this in here because as we're getting you guys practice for the practical exams, we're wanting to make sure that there's at least one drug-related problem that you can identify from the med list. Because you would be surprised, maybe not, you guys have been working out in the pharmacy world for a couple of years, but you would be surprised at how many issues you can identify just by looking at somebody's med list. So that's a big one that stuck out to me. Certainly we're worried that she doesn't have insulin today. We need a plan for that. But when we put this lady back on insulin, we need to make sure that she is dosing it appropriately. Okay, how about lab information? That's, of course, a big part of objective. So what kind of labs do we have for this patient, and how would you interpret those? I'm going to throw this one down to Augusta because we haven't heard from you guys yet. So, Augusta, you want to run us through some of your interpretation on these labs?
What did she ask?
Run us through on the lab.
We need an updated A1C.
Yeah, that would be really nice.
Honestly, everything is fine except for high glucose and cholesterol. Her A1C is above goal, but it's from September.
Yeah, the most recent A1C we have is from September and it's still above goal, so a new A1C would be nice. She hasn't been taking the insulin though, so it might not be appropriate.
Okay, so we've got an A1C that's about maybe 5-6 months old, right? What's your interpretation of that A1C?
It's still above goal.
What goal would you set for this patient?
Less than 7? Less than 7%?
Yeah, I would agree with that. I've shared with you guys before, I typically use the ADA guidelines in my practice. ADA does give the option to set less stringent goals for patients who have a lot of poorly controlled comorbidities. Maybe they're older, it's hard to control their blood sugar. This lady certainly has a lot going on, but my perception is that she's appropriate for a goal of less than 7. So I would agree. It'd be nice to see an updated A1C, but we probably want to get her back on therapy first. Okay, what else is significant about her labs?
I found an average blood glucose of 203,
Yes.
but I don't know when that was from.
I think it was from,
That's just what you can interpret from her A1C.
yeah.
Okay. I mean, we have a lipid panel from that same day, but that's also old.
I mean, her numbers are bad, but it's not as relevant because we're just trying to percent.
I know we've got other labs.
Triglycerides?
Triglycerides? Okay, so we should have an entire lipid panel on her, right? So what does her lipid panel look like?
It's not terrible.
Yeah, it's not.
It's really not bad at all.
It's not terrible.
It's not terrible. Okay, why is it not terrible?
I mean, she's like kind of basically meeting all the targets.
Her total cholesterol is just a little bit high, and her triglycerides are just a little bit high. And we're also not necessarily concerned with her absolute values as much as we are with the percent reduction with her statin therapy.
Okay, so we're thinking about, yes, what is this lipid panel? What do those numbers mean? But we're also thinking about her global risk, right? You guys have already told me that this lady has stroke, so that's an extremely important part of her past medical history. LDL, what do we have for her LDL value?
97.
97, okay, how do we feel about that?
Should be less than 70, right?
I like it, I see some, who better, might be okay? Okay, we'll
I got the
talk
new
about
one.
that in a little bit. But yes, we do have a lipid panel for her, which is important. What other, I'm still sticking with objective, what other objective information do we have? We got A1C, lipid panel, what else?
There was a basic metabolic panel taken in November, but we don't have results.
So something pending potentially. Do we have a BMP prior to that?
I didn't see it.
I thought so.
Other campuses, can you see when I pull up the EMR like this? I think it still shares what I'm doing over here, but can you see this?
Yes, I can.
Give me a wave. Okay. Looking for labs.
Yes, ma'am.
Okay, so this looks like a CFP, right? Because I've got liver function and renal function on here. So what do you guys think about this? Anything here that we should be concerned with? Or
Her glucose
what is
high,
notable?
but we expect that, but everything else is within normal limits.
Yeah, so the glucose is a little high. We don't know if this lab was taken fasting or not, or the timing of her insulin, right, when the lab was drawn. But yeah, I'm looking at renal function, right? So creatinine is within normal limits, that's all fine. I'm also looking at her electrolytes. So why are we concerned about electrolytes?
She's taking my
Are those anaerobic that affect her potassium levels?
Absolutely. So I'm thinking antihypertensives, right? So lisinopril, what else could impact her potassium?
Diuretic.
Her HCTZ, absolutely. So both of her antihypertensives can have an impact there. Potassium looks fine at 4.3. Okay, one other objective piece that I'm thinking of that we haven't touched on yet. So we've talked A1C, lipid panel, kidney function, electrolytes. Her blood pressure? Yeah, blood pressure, absolutely. So what do we know about this lady's blood pressure?
Vital sign.
It's chronically uncontrolled.
I hear chronically uncontrolled. Yeah, I agree with that. So we've got some historical values here. What should this lady's blood pressure be, or what's our blood pressure goal for her?
What guidelines are you looking at?
What guidelines you want?
Blood pressure goal?
Less than 130/80.
Less than 130/80, absolutely. So Obviously, we've got a couple of different guideline statements that I know that you guys have touched on in other classes. ACC AHA, that has relatively new guidelines, made that goal more stringent for patients, especially those that are high risk, which I think we can argue that this lady falls into that bucket. If you look at ADA guidelines, right, you see some options to have a less stringent blood pressure target for patients who are older, multiple comorbidities, may be difficult to manage. But I don't think this lady's here yet, right? She's only on 2 antihypertensives. She's relatively young. We just need to connect her a little bit better with healthcare. So I think that blood pressure goal below 130/80 for her is appropriate. Good stuff. Okay, so I think we've hit on most, if not all, of what was on my list. So again, I'm thinking of objective from today versus historical objective. So these are all the things that we can use to assess her current drug therapy and help prioritize her problems. Does that sound reasonable? Any questions from that so far? Okay. Are you guys with me? Yeah. I feel like I'm being boring. Sorry. I don't have a song and dance jig for this. I'll have to get better at that. This is pretty much, I will highlight though that I think this is realistic. This is pretty much what I do every day. I think it's fun. Digging through the chart, meeting patients, trying to figure out what to do with their drug therapy. This is my job. So hopefully we're learning some stuff. I think we are. Okay, so now let's get into the meat of what we really want to talk about, which is problem prioritization, right? So maybe walking through the subjective and objective is not the most fun thing, but you have to do it, right? You have to know about what your recent lab values are or what lab values you are missing and might want to order. And you need to talk to the patient. You need the history as reported by them and as reported by the chart. So what do you think the first priority problem is? What would you do first for this lady?
Her foot.
We need to treat her foot infection.
Okay, so I heard we need to treat her foot infection. Absolutely. I agree. And so when I thought about prioritizing here, I kind of broke off my priority problem number 1 into 2 pieces, right? Because I think the foot infection is extremely important. If we don't treat that, what can happen? Amputation, potentially, right? Now, certainly that's down the line. That's a really significant issue. But we don't want this lady to be losing a toe, certainly. So we need to make sure we treat it so this doesn't get worse. But why isn't it healing in the first place? Because of her uncontrolled diabetes, right? The fact that she's been out of insulin. Now, certainly, yes, she's only been out of insulin for 4 days, and you might think that's not very long, but this could be a pattern, right? We already know that there's some issues with adherence at play. So I'm looking at this twofold. Let's treat the infection, and let's try our best to prevent any further infections. Okay, so where do you guys want to start? You want to go down the insulin path first or the infection path first? Infection. Okay, so do we have a recommendation, or how could you get to a recommendation?
DSA.
Is that what she wants?
So how would we treat this? Like, what type of infection would you classify this as?
A diabetic foot infection?
Diabetic foot infection, okay. So globally, skin soft tissue? Yeah, I'm seeing lots of knots. Good. So what kind of antibiotics could we use for that? Or what's our decision pathway there? Because we got lots of different antibiotics out there, right? So I'm thinking about what's on my formulary, right? What's going to be cost effective. Obviously, you guys don't have that information readily available. So what kinds of antibiotics could you use to treat a diabetic foot infection? Or what's your first decision, I guess, really, before we go into specific antibiotics? Okay, so we need to think about how broad we want to cover, right? So bugs that cause skin soft tissue infections, the scary one we think of is MRSA, right? If we want to treat that, then we need to think about some specific agents that cover that, absolutely. But even before you get to that point, there's something else that I'm thinking of.
Whether the infection is purulent?
Okay, so in terms of how severe is the infection, like can you drain it, is it pussy, is it red, absolutely, all of that, because that's going to play into our decision to do what? We're close.
IMD,
Say it again.
incision and drainage.
Oh, like if we need to drain it. Keep going.
What?
Say it again. Yes. Thank you. Shout it out. Shout it.
Inpatient or outpatient treatment?
Yes. Yes, yes. So even before we go down the path of, what bug are we looking at and what do I have on my formulary and how much is this going to cost, right? We need to think, how sick is this lady, right? Because if we're really worried that, let's say maybe she's got fever, she's decompensating in some way, and we know her sugar's already high, right? So we have to think about how aggressive, I guess, we want to be with where she needs to be treated, right? Is this an inpatient versus an outpatient situation? So I've kind of given you some spoilers about how I weigh that decision in my mind. But do you think this lady needs to go to the hospital?
No.
Nah, I don't think so, right? We know that her infection is likely significant enough to require an antibiotic, right? But I don't think she's at the point where we need to put her on IV Zosyn or something like that, right? We can scale that roll back a bit. Okay, so once you've figured out outpatient versus inpatient, then we need to think about specific agents. So does anybody have a specific agent that they recommended? Or walk me through your thought process of some agents that you picked among?
Yeah.
Okay.
We have the almost every day. She's very and I just automatically assume that she's on.
Okay, so we have got, I like it, thank you for your confidence. So we have got a recommendation for Bactrim DS, 2 tablets BID times, you said 7 days? Okay, anybody agree? I see some nodding, you've got some votes. I think that's reasonable, right? So again, if we're thinking of our big bugs, right? Which this, I again purposely edited this case a little bit to make your decision kind of funnel towards MRSA coverage. Because realistically, in a clinic setting, the pharmacy team is not the one that's going in and saying, I think we need to treat for MRSA, right? Now, what does happen to me often in clinic is I'll be seeing a patient for diabetes management and they say, hey, you know what, can you look at my toe? Because I think I've got something brewing here, right? That happens all the time. So let's take your shoe off, take a look, and then I phone a friend, right? I take a look at it, I say, how severe is this? Do I need to call in another healthcare provider that can help me make this decision? And I go grab one of our nurse practitioners or physicians, I say, hey, what do you think? Do you want to treat this? And we have a conversation about it together. So that's kind of, intentionally how I funneled this particular note. So if we are thinking MRSA coverage, Bactrim should absolutely be on our list, right? And I definitely saw some head nods for other people that might have recommended that. Is there anything else that we could use? Again, think outpatient PO. And phone in our other campuses. Anybody pick something other than Bactrim for this lady?
I think she wants Augmentin, but I didn't say that.
Oh. What?
Augmentin BID.
You could use Augmentin.
Never mind.
Okay, could you use Augmentin if you're concerned about MRSA?
No.
No.
No, so it should be on your list, right, for skin, soft tissue, diabetic foot, if you're thinking maybe less severe, maybe unable to be drained, something like that, and MRSA is not in your bucket. Augmentin would be okay. But if we're trying to cover MRSA, what else could we use other than Bactrim?
Clindamycin.
Okay, I'm going to vote for clindamycin, that's reasonable.
Why are we
Something
thinking
else.
that it's MRSA?
What's that?
Why are we thinking that it's MRSA?
I think based on the presentation, so in the note, it talks about pus, I believe, and ability to be drained, also some just redness and swelling in the area. This is loosely based on a similar situation I had in clinic where a patient had a boil type presence in which the provider chose to cover for MRSA. And I think it's probably based on, we know uncontrolled diabetes, right? So healing is going to be an issue. And if we're able to culture something and see that it's not MRSA, then we can de-escalate. Does that make sense?
So we're just like better safe than sorry.
Yeah, because if let's say we did something like Augmentin, and it didn't heal as quickly or it continued to persist, then we might be in a situation where it's getting worse. So it's a great question. There's not a hard and fast rule for this. In clinic, I'll tell you what I have on my formulary. I have Augmentin, I have Keflex, I have doxycycline, I have clindamycin, I have Bactrim, and I have Z-Pak. That's my arsenal in terms of antibiotics that we use. Sometimes I have Levaquin, but not always. So when I'm making a decision or when I have a provider ask me about it, I'm usually dividing into what type of infection am I dealing with, right? Do I have UTI, skin, respiratory? Those are the main things that I see. For a skin soft tissue, a lot of our providers want to go to something like Bactrim just in case. But I think that, now we can kind of take the decision on Bactrim versus something like doxycycline versus something like Clinda. So is there a particular reason or monitoring that you would need to do with any of these antibiotics?
Hyperkalemia.
Or kind of why did you choose one over the other?
You couldn't use Bactrim if she had a sulfa allergy, but she's good.
Okay, so we're considering antibiotic allergies, absolutely. So nothing remarkable there. Earlier I asked you guys about infection history, right? So let's say this lady had, history of recurrent UTI or something like that, and she'd been treated with several types of antibiotics recently. I take that into consideration too, but I don't think we have to worry about that as much. There's something I'm thinking of with Bactrim that has to do with drug interactions. Anybody pick up on that?
Oh shit, no.
It's okay if not. I would say it's probably less clinically significant for this particular lady, but again, I'm drawing on another case I had recently in clinic where we selected doxycycline instead of Bactrim. And it had to do with other medications on their list.
Would it be because I think Bactrim usually causes, potassium or electrolyte?
You got it. Yeah, so Bactrim can, when combined with other medications that impact potassium, can increase the risk for hyperkalemia. Yes. And again, not this patient, but a situation I had recently. We selected a different antibiotic because that patient had lisinopril and spironolactone on their list, and they had poor renal function. So those are things, multiple concomitant meds and renal dysfunction kind of tipped our scales one way or another to say, you know what, even though this is a short course, let's not mess with something that could potentially have that impact. So yeah, again, for this lady, I think either would be appropriate, but I do think about monitoring there. And any other interactions that we might see. Okay, so let's, this is good conversation. In the interest of time, I want to go ahead and move on to her other priority 1 problem. So again, I divided this into twofold. I think infection is absolutely at the top of our list. We're treating the infection because we want to make sure it heals appropriately, and it's currently not healing appropriately because of her uncontrolled glucose. So what do you guys want to do about her diabetes today?
Just counsel on the importance of taking her insulin as prescribed.
Okay, so we've identified a significant adherence issue first of all, right? And that she is using this supplement instead of her insulin on some days. And we've not documented what that's done to her self-monitoring, right? Let's talk for a minute about insulin access. So if a patient comes in to the doctor's office and says, yeah, I'm prescribed insulin, but I ran out of it. I haven't been doing it for a couple of days. How could you help that patient get insulin if they don't have insurance? Or if they tell you they don't have any income?
If they have some income but not much, you could get them on one of the basic types of insulins that they have at Walmart for $25.
Okay, so option number 1, an option on our list, absolutely. We've got some insulins that can be purchased without a prescription at a reduced cost, right? So pros of that, the patient may be able to afford that insulin, right, and not run out of it. What are some cons of that plan?
Might not be optimal.
In what way?
Yeah, type of insulin's available.
Okay.
Different than maybe what we would ideally like to have her on.
Okay. So right now she's prescribed Humulin 70/30 mix, right? Could we get that? Could we get that without a prescription at Walmart? We could. We could. How much is it going to cost her? Anybody know? About $25 a bottle. Okay? So it is going to depend on her dose, right? That could be $25 a month or that could be $75 a month, depending on how much she's on. Now, certainly she's not on that high of a dose yet, but I'm just speculating. So yes, that is an option if we're concerned. Well, this patient can't afford something else that I'm prescribing and she doesn't have insurance, so we're going to use this option instead. What is something else that we could do?
Apply for patient assistance programs.
Absolutely. So utilizing some resources through drug companies can be especially helpful. We do a lot of that at Mercy, so I'm decently well versed in that process. A lot of times, the patients I'm interacting with are low health literacy, right? It's hard for them to fill out forms. So we have a resource for that in our clinic, and a lot of underserved clinics have some sort of a resource that will help patients fill out information so that they can get insulin either from no charge or at no charge from the drug company, or a small fee. Okay, so again, just things to chew on, right? Because access is an important theme of this case. So is there anybody that would want to try this lady on a different regimen? I don't know if you got that far. You're probably thinking, let's just resume what she needs, right? But did anybody take it one step further and think about switching out her diabetes regimen? Yeah, what do you think?
Considered Lantus because it'd be optimal for like basal. So I just I put her total daily insulin. I didn't really notice that she wasn't taking them. One, how to interpret that, but then 70% basal from Humulin 70/30. So I took that and gave her Lantus at that units.
Absolutely. So that's a great option. So the other reason why I consider that too is let's think way back to her subjective information that's important. She's told us some stuff about her diet, right, and her day-to-day life that's not super consistent. So if she's eating a really big meal in the middle of the day, but maybe a lighter breakfast or doesn't have time to stop for dinner at work, premix insulin could get us into some trouble, right, in terms of hypoglycemia and just dose consistency. So yeah, absolutely, I think that's reasonable. So we're considering 70% of her current dose would be NPH, which would be basal, and we could transition something like that to maybe something like Lantus. Absolutely. Again, guys, the other maybe easier plan, right, is to identify that she's out of insulin and we just want to put her back on something consistent and assess her level of control that way, and that's appropriate too. But we want to make sure that this lady has a regimen that's reasonable for her.
Why would we put her back on what she was on if it said we've counseled her on it several times and she's still not doing it right? So I don't know. Do you think it's because of us or is she just I don't know?
So this absolutely is a conversation with the patient, right? Because right now we're not really sure. I mean, we know she's run out of it. We're assuming that's cost related, but we don't know. So she's run out of it, or she hasn't taken it for 4 days. And when she was taking it, she wasn't taking it at an optimal level. So yeah, I think that you could make a case for swapping her regimen out altogether because of that. The other thing I think about, just to our conversation about patient assistance programming, is time. So a lot of times, let's say we're going to process some paperwork for something like Lantus. Can I get Lantus for that lady today? Probably not, right? Now at Mercy, I've got some clinic stock of different insulins at my disposal that I get samples of. So I might be able to swap her to something before the long-term supply comes. But just from a logistics standpoint, sometimes we'll put the patient back on what they previously had if we've got that, and then take about a month or so to transition them onto something new. But yeah, no, great questions, guys. Great questions. So again, summarizing our priority problem. So these are the two things that we keyed in on. And I tried to break this out in terms of drug-related problems, right? So she's indicated for some drug therapy, both to help resolve her infection, but also as needed for her diabetes. We talked about some different antibiotic options, that we have, as well as what is on my formulary at Mercy, which ones cover MRSA, drug interactions, and monitoring. So again, there's not a perfect plan, and I think that you guys have tossed around a lot of different ideas, which is great. One thing we didn't talk about yet, but I guess we touched on it briefly. We decided that this lady is appropriate for outpatient management for her infection, right? We also have to make a decision about whether she's appropriate for outpatient management for her diabetes, right? So sometimes we're in a situation in clinic where a patient comes in with an acutely high blood glucose and either they're out of insulin, they've never been on insulin, and we're asking some more of these questions about the types of symptoms that they're having. Certainly we don't want to withhold, let's say, fluid management, right, from somebody who's approaching DKA or something like that. I didn't perceive that this case was that significant because we have identified a reason for this acutely high blood glucose. But we know it's going to impact her wound healing. So this is something that I consider. Now I mentioned if we're worried about hyperkalemia, again, a situation I had recently in clinic where we chose to do Doxy, but something like Bactrim is also appropriate if you're worried about MRSA. And then our decision to resume insulin therapy, this is broad. This could be putting her back on her premix until we can get something like a basal or transition her to something else. But bottom line is we need to restart this lady on insulin therapy today, and we need to educate her on the right way to use it. Okay. I think we've hit on all these points. What do you guys think? Lifestyle, that's a big one. You guys have mentioned that multiple times, and I'm glad that you have, because again, it keeps coming back. We're bringing it full circle, right? We can make the best, most beautiful med list for this patient, but if she doesn't understand maybe why she's taking certain medications or how certain medications work with her day-to-day routine, then it might not matter. So we need to make sure that we do something that's also just realistic for her. Okay, so obviously this lady's got other issues just based on her historical past medical history and the labs, the vitals, the objective data that you guys have told me about. So if we move on to our next priority problem, after her diabetes, what would you guys set as next?
Hypertension.
So this, I apologize if that got a little muddy. Priority problem 1 is infection and acutely elevated blood glucose. A very, very close second is just her long-term control of diabetes. So is there anything, did anybody else have any other recommendations about her diabetes therapy? Anything else that you would utilize? What else is she on? We'll talk about that for a moment.
Metformin.
I thought I heard somebody say it. What else is this lady on?
Metformin.
Metformin, okay. So what kind of monitoring parameters do we have for metformin? Is it appropriate for us to continue that?
We want to monitor serum creatinine and eGFR, but she's okay.
Absolutely. So we're paying attention to her renal function, which right now looks fine. And metformin is our favorite, right? It's a sensitizer. It helps our insulin work better. That's a lot of times how I explain it to patients. So we want to make sure that she is continuing metformin in addition to her insulin therapy. Are there any other drug classes that anybody considered? Yeah, we think has.
Would she be a candidate for long-term doing like a GLP-1 or a SGLT2?
Okay, so walk me through your thought process on that. So considering, I want to make sure we get that for other campuses. We're considering other drug therapy options like a GLP-1 agonist or an SGLT2 inhibitor. So what do you think?
I was just looking at the new guidelines that came out, and it was talking about people who have like an established ASCVD or CKD risk, and she had a stroke 5 years ago, so under like the category for ASCVD, it had GLP-1 agonist or SGLT2 inhibitors listed.
Yes. Do you know why those show up in the guidelines?
They have proven cardiovascular disease benefit.
Mm-hmm. Which one? No, this is great. I'm gonna pull up our guidelines too, because I've got them up here somewhere.
Liraglutide and empagliflozin.
I heard empagliflozin.
Liraglutide, she said.
This is it's a lot of text, guys. Sorry, that's kind of small. But this is from, I'm assuming you guys have had a case already this semester that's discussed diabetes in some detail? Oh, so, okay, wonderful. So you've seen these guidelines. So the ADA standards got updated just about a month or so ago. And I know that this schematic is a little busy, but something that's really nice about the ADA update is they are focusing a lot more on patient-specific parameters, right? So thinking about, does this patient have heart disease? Do they have heart failure? Do they have CKD, et cetera? And just looking at some of these newer drug classes and how they've been studied. So the SGLT2 inhibitors, right? We've got empagliflozin and canagliflozin that have positive cardiovascular data. And then our GLP-1 agonist, liraglutide, is the one that's got the FDA indication at this point, but semaglutide has some good data as well. That's Ozempic. I have not used that agent yet in my practice, so I can't speak on that too much, but it is out there on the market. And so that's based on how these drugs were studied. So I would take a look at, our patient, right, and is she similar to the patients that are in these trials or not? I do think, bottom line, that she does have ASCVD, right, and we know she's at high risk for another event because of that. So one of these drug classes would be appropriate, okay? A lot of the patients in these particular trials had MI as their prior CVD indication, but there were patients in those trials that had history of stroke too. So I think it's risk benefit. Certainly when you look at the side effect profile, you've got some challenges with either of those agents in terms of monitoring and patient counseling. Is there one in particular you would pick, or did you get that far? No, that's okay. That's okay. I think that, let's see, we've got about half an hour left in class, right? So I think we've got time to spend a few more minutes on diabetes. So let's talk about that for a moment. So anybody have any thoughts on GLP-1 versus SGLT2?
I picked liraglutide because she is obese, and that's also indicated for weight management.
Absolutely. So GLP-1s have some positive effects in terms of helping the patient to feel fuller, right? And possibly assisting with some weight loss. So I think that's reasonable. Something to consider. So let's say we kept this lady on Humulin 70-30 mix. Could we add liraglutide to that? I see some really good faces in the audience. This is good. Everyone's like, I don't know. So there's not a lot of data out there on basal bolus insulin plus GLP-1. We have a few patients at Mercy who are on it. Really, the theory is to help with insulin sensitivity in somebody who's on really high insulin doses. But I would say more commonly, I use GLP-1s as an add-on to basal insulin. So I'm getting a little bit more prandial control there, but I have the benefit of weight loss versus weight gain with something like bolus insulin. And then certainly some of those cardiovascular benefits that we're aware of. So I'm thinking long term, if we think back to our idea about doing something like Lantus, maybe we switch this lady from premixed insulin to a basal product and add a GLP-1. I mean, it's not going to happen today, right? But that's okay. We're going to end here. We got time. So we could follow this lady for a few months and really tune up her medications really well.
Dr. Rubich?
Yeah. What you got?
Do you expect her to have to decrease on her insulin if she was to start the GLP-1 agonist, if she didn't make any lifestyle changes or anything like that? Just medication adherence alone?
Yeah. So good question. And we're thinking along the lines of hypoglycemia, maybe? Yeah. So GLP-1s by themselves have a pretty low risk of hypoglycemia just based on how they work, right? But anytime you combine them with an agent that causes hypo, so insulin, any secretagogue, right, you do run that risk. Something I've also seen in practice is some pretty substantial GI effects. So lots of counseling for nausea, vomiting, especially over that first few weeks of therapy. So absolutely, you have the option to preemptively reduce the insulin dose a little bit or just monitor over the first couple weeks and see. I've done either. But making sure the patient understands that based on how the drug is working, they might not feel like eating as much as they're used to, and they just might feel sick. So if they're consuming less overall, that could result in hypos. So yes, absolutely big patient counseling points there. What about monitoring with an SGLT2? Those agents kind of have some tricky side effects that go along with them. So if you started this lady on an SGLT2, what kinds of things would you want to monitor?
Signs and symptoms of potential yeast infections.
We're peeing it out, right? So these agents work in the kidney, and they help with the excretion of glucose. So yeah, UTI, yeast infections, things like that can be seen. They're working in the kidney, right? So again, her renal function is normal, so we feel fine about that, but we probably monitor that. There's something on her list, on her med list, that I'm considering too. So if we think to our mechanism too. So if we think about how SGLT2s work, so if we're losing some volume, that could be a good thing, or it could be a not good thing.
He's already on a diet, and SGLT2 causes you to pee more.
Say it again?
I said SGLT2 causes you to pee more, and she's already on hydrochlorothiazide, so everybody's kind of...
Yes. Diuretic, right? So I would worry about things like hypotension, right? Maybe losing too much volume. So it could be a good thing because those agents can cause a little bit of weight loss as well, based on how they work. But if you put them on board with somebody who's on a diuretic, then sometimes you can have some not good side effects. So again, just thinking pros and cons for either, but I think that's a good discussion. Okay, in the interest of time, we'll go ahead and move along. What other kind of priority problems show up on your list? I've got 3 more on my list, but I think they're probably a quicker discussion than our diabetes. So what's next? What should we manage for this lady next?
Hypertension?
Hypertension, okay. So we've discussed her blood pressure goal is less than 130/80. What do you guys want to do about her hypertension and why?
Increase lisinopril dose.
Okay, so we can increase her lisinopril. How would you monitor that?
Serum creatinine and potassium.
Okay, when?
2 to 3 weeks from now.
Great. So, and really, with either or, right? So we could increase her lisinopril. What else could we do? So she's on, what dose of lisinopril is she on? 20, so we can take her from 20 to 40, right? And monitor that renal function, monitor her potassium in about 2 weeks. What else could we adjust? We could adjust her HCTZ, right? And same monitoring parameters would apply, right? We'd still be monitoring potassium, we'd still be monitoring renal function. Now, again, thinking back to our conversation, we'd probably be asking some follow-up questions, right, before we make that call. We know that adherence has been an issue in the past, so before we go up on a dose of a med, we better make sure that she's taking both of these things consistently, right? So I know you guys would do that before you intervene. Okay, what would be, oh yes, please, give me a hand raise.
If you increase the dose of hydrochlorothiazide, do you need to worry about her uric acid levels?
Okay, so that's a good call. Higher doses of thiazide can cause some metabolic issues. What's our current uric acid?
I didn't see one on the lab.
Okay, so if we do not currently have a uric acid, question would be, is that something we need to monitor? It's a good question. I would say in the absence of a gout diagnosis, probably not. Where I typically see thiazides cause metabolic issues is once we get into doses of like 50 milligrams a day. So she's on HCTZ 12.5 right now, right? If we were going to optimize her dose to 25, I would definitely be watching the renal function and potassium, but I probably wouldn't go down the uric acid trail yet. Okay, if she had a history of gout, Yeah, sure thing. Sure thing. I think in my notes I have this as priority 4. I do. But I think hypertension and lipids are both on there. So again, BP's consistently elevated. Both of her current medications are first line. So the good news is I don't think she's on anything inappropriate, right? I think she's on the right drug classes, but we might want to make some adjustments based on adherence and monitor appropriately. So what is next? What else is on our problem list?
I have another question about the hypertension.
Oh, yeah, please.
Assuming she's adherent and everything is fine, how do you decide between the lisinopril and the hydrochlorothiazide?
That's a good question. There's not a hard and fast rule on this. Sometimes, again, thinking back to this lady's lifestyle, she's a waitress, she's at work a lot, she's on her feet. If we increase the diuretic, it might increase her urination during the day, which, if her blood sugar's been running high, that's probably already a concern for her. So I would think about hydration status and things like that. But honestly, from an efficacy standpoint, I would say either or. You know, both of those agents require some follow-up dot monitoring. If you have it on something like a calcium channel blocker, you have the benefit of not having to send it for labs. But either of these adjustments would necessitate some labs. So that's a great question. Great question. Okay, shall we go down the lipid trail? Spoiler, that's on my list. I actually have that as my priority problem 3, is her lipids. And so you might be thinking, well, wait, we don't really know enough. We don't know as much as we want to know about her lipids to make a decision, right? Is anybody thinking that?
I know it's my mom's doctor.
No? You guys are like, come on, you taught us this. Go have a stroke, right? True. So what do we want to do with her lipids and why?
Needs to be on a high intensity statin because she's had a stroke.
Absolutely. So we know that she's in the secondary prevention benefit group, right? She's our highest of the high in terms of risk level. What is she currently on?
Simba 40.
Simvastatin 40.
Okay, so simvastatin 40, not high intensity, right? So what would you switch her to? And how would you monitor that choice?
Torda.
You can switch it to a high intensity, for example, like torvastatin 40 to 80 milligrams, and you would monitor lipids in 4 to 12 weeks and look for a 50% reduction in LDL.
Okay, perfect. So we're monitoring in part to tell us about adherence, right? You know, if we switch this lady from simvastatin to atorvastatin, we want to make sure that she's taking that medication and we see an appropriate drop in her LDL. What's tricky, but again, what's realistic about this case is we've got a lipid panel, and we are assuming that that lipid panel is on simvastatin, right? We might not know what this lady's baseline lipids look like because she's probably been on simvastatin for a decade, right? So this LDL of 95, 97, whatever it is, we could look at that and say, yeah, that's probably okay. But we know that she's secondary prevention, she's super high risk. So we're going to want to optimize that high intensity statin if we can. Are we aware that some new lipid guidance has come out recently?
Yes.
I see some nods, so that's good. What can you guys tell me about new lipid guidance? It's not anything crazy, but it's important.
Is it that you want LDL less than 70 in second prevention patients?
Yeah, who said that? Thank you, ma'am. Yeah, so ACC, AHA, I'll preface this. There's lots of different lipid guidelines out there, right? Last year in therapy, we talked about ACC, AHA the most because that's what I call the quote statin guideline, right? Because it helps us decide who needs to be on a statin and why. And those are still our most widely used therapies for lipid lowering, and they're the drug class that has the most evidence, which is really important. But what we're seeing is now that we've got some new agents on the market that are super potent, like the PCSK9 inhibitors, we have some data, although it's only about 3 or so years of data, it's data to show that you can lower somebody's LDL pretty low and not increase the risk side effects. At least this is what we think, right? So, knowing that the higher your LDL is, the higher that risk level is, if we've got somebody with secondary prevention, the new guidelines really do support pushing a lower LDL target. And so, yes, whoever said that in the back, thank you. So LDL below 70 is something that they're recommending if you've got somebody who's already optimized on a high-intensity statin, okay? So again, this is down the line for this lady, right? Today we're talking about, hey, I noticed that on your med list, you're on a moderate intensity statin, and I want to reduce your risk as much as I can, so I'm going to swap you to a high intensity. But if we swapped her to a atorvastatin 40, let's say, or even 80, and maybe our LDL is still in the 80s, and we need to incorporate some lifestyle as well, it sets the stage for other agents to be utilized. So if we pretended that this lady was already on, let's say, atorvastatin 80 with an LDL of 95, that opens up the floor to say, well, does she need to be on another lipid agent or not? What other lipid agent could we use? So probably not a PCSK9, right? Because again, I'm thinking in my standpoint, cost is extremely important. Those agents do have patient assistance programs and things like that. So if we really thought she was indicated for something like that, we might consider it. But from a cost and efficacy standpoint, there's another option that I would do first. So, Zetia, absolutely, ezetimibe. That's going to be a good LDL lower that you can add to a statin. Pretty low side effect profile based on how it works. It has some studies to show that in combination with a statin, it can be helpful for risk reduction. So, absolutely. So again, talking about monitoring, patient counseling, I think we've got any drug interaction concerns. Anytime I'm thinking about statins, I think interactions, right? So is there anything on her profile that you would be concerned about from a drug interaction standpoint? I don't think so. Simvastatin probably has a higher chance of causing an interaction than atorvastatin, right? And I don't see anything on her profile that's a 3A4 inhibitor or anything like that. So, fine with me. All right, home stretch, guys. We're almost there. We have also briefly mentioned our last priority problem, but I think it's important that we keep it on our list. So what's something that we haven't visited in a while that we need to discuss with this patient? What? We mentioned it when we talked subjective. So that shows up on my list too. You know, again, certainly not as significant as managing her infection today, managing her glucose today, and all of that. But I think this merits a mention because I do see this a fair amount in my practice as well. And I'm sure for you guys that are working out in the community, you see this kind of stuff all the time too, is patients don't always disclose supplement use. And as healthcare professionals, we have to be really careful not to appear judgmental, right? This is hard, right? And we talked about this in OTC, so take your minds back to P1 for a minute. But, you know, I think if a patient is telling you about a supplement that they're taking, then it's appropriate for you to ask them questions and make some recommendations, but it's also appropriate for you to weigh risk versus benefit, right? We might not know very much about the supplement that she's taking, but if we can determine that it's reasonably safe, then you might not need to tell her to stop it, but guess what? If it's interfering her ability to take her insulin every day, then that's a problem, right? So it's really kind of partnership with the patient, making sure that they understand why you'd like them to take their insulin every day and why that's going to be helpful for their diabetes, but maybe also being culturally sensitive to something else that they want to take in addition. If you feel like something is unsafe, then it's also your job to speak up, right? If you found maybe a drug interaction or some kind of issue with a supplement, then you should share that information with their patient, but recognize that they're part of that decision-making process too. So again, if someone's asking questions, then it's appropriate to give your professional advice. What else? Anybody else have any priority issues on their list that we didn't talk about, or any issues that you found in the med list?
She said she has back pain.
I believe you. What can we do about her back pain? Sorry, I didn't pick up on that.
Maybe some Tylenol?
Okay, so thinking about a safe, right, OTC option, maybe avoiding an NSAID, especially if we're going to use Bactrim for her infection, right? We might want to avoid NSAID, something else that's potentially impacting the kidney. And just long-term NSAIDs are not great for lots of reasons, blood pressure, all of that. But yeah, we could recommend some PRN Tylenol. Again, think back to this lady's lifestyle, right? She's on her feet a lot, we assume. And so it might just be about taking breaks when she needs it at work and maybe doing some PT-like exercises that can help that as well. What else? There might be something else I missed, so I'm...
She's on vitamin E and a multivitamin.
Okay, so why do you think she might be taking vitamin E? Any ideas there?
She said it's for her circulation in her legs.
Okay. Do we think that, so again, I'm thinking risk-benefit, right? Do we think that that supplement is safe for her? I can't think of any drug interactions offhand. It's fat-soluble, right? A, D, E, and K. In terms of circulation, things like that, I'm not sure. It could be an opportunity to look at the multivitamin that she's taking, right? And say, well, you're already getting this vitamin or some of these other vitamins, and you might not need that if we're worried about polypharmacy there. I think that's a good call. Yeah.
Looking for B12 to make sure it's timeless and she's been on metformin for a bit of time.
Okay, so thinking about some other monitoring there. So yeah, so B12 deficiency can happen with long-term metformin use. Where I've seen that be a problem is with neuropathy. So she hasn't reported any kind of nerve pain that I could see, but certainly if she had neuropathy and B12 deficiency, that can go hand in hand and make it worse. And B12 is a pretty easy vitamin to supplement with, right? And in fact, her multivitamin might already have B12 or B complex in there. But yes, yes, yes. Well, this is good stuff, guys. This is my very, very brief summary. I think we had really great discussion today, so I appreciate you guys talking to me. But these are just some things that this case made me think of. You know, again, in AmCare, I spent a lot of time talking to folks and just being a Sherlock, right? You would be amazed what you can learn by just spending 10 minutes with somebody. And so I would advise you as you get out there and are on rotations, your chart tells you a lot, right? You can get a ton of information from your chart. But you're always going to need to talk to the patient to see things about adherence, their day-to-day life. Answer any questions that they have, right? So follow-up questions are key. As you prepare for practical and you have your practice session on Friday, I would think about monitoring your plan, right? So I know Dr. Phillips is going to go through with you guys kind of the systematic approach that you take. But you want to be able to prioritize your problems and then make your assessment, make your plan, and tell us how you're monitoring it. And if you can do that, then you're going to be ready for rotations, I promise. Believe. Well, we're done a little bit early, guys, so certainly if you have any follow-up questions, I am here. You're always welcome to shoot me an email. If you want to see any of my other notes on things, I'm happy to share them with you. But on ELC, I will make the slides available. I'll also make the guideline statements available that I used when I worked up the case, if that's helpful. I know it's a lot of stuff that you've seen before or probably already have in your files, but if you want it, it'll be up there for your grab, okay? Thanks, guys. Have a great week.